Okay, we're going to move on to enzymes and liver function. We find that a great many of enzymes in the human body are found in the liver, so I kind of decided to clump these two together. Okay, we're going to start with a little bit of a review of the enzymes and how they work. You need to be familiar with the definition of an enzyme. Enzymes perform the specific biological functions that catalyze biochemical reactions without altering equilibrium point of reaction or being consumed or changed in composition. So they drive reactions to happen all over in the human body. They're found in all different types of tissues and organs within the body. They're made up of proteins. And we do have things called isoenzymes and cofactors that do go along with causing these reactions to happen. Things that you need to remember and be familiar with are things like an international unit. When we talk about an enzyme and how much enzyme we have within the human body, we talk more about the energy of that enzyme and not so much the weight. When we talk about other things, that everything seems to have milligrams per deciliter. Well, our enzymes have international units per liter. An international unit per liter, or IU per L, is the quantity of enzyme that catalyzes the reaction of 1 micromole of substrate per minute. So it's a little bit different than some of the other things that we do. Something else you want to familiarize yourself with is the activation energy of an enzyme. The activation energy is the energy required to raise all molecules in 1 mole of a compound at a certain temperature to a transition state at the peak of an energy barrier. So again, we're looking at the energy of these enzymes. When an enzyme reaction is run, there's usually an enzyme plus a substrate going to an enzyme substrate complex, which ends up with products and free enzymes, as you can see from the picture that I have here in the middle. A couple other things that you want to be familiar with is the difference between a first order kinetic and zero order. The first order is where if the enzyme concentration is fixed and the substrate concentration is varied, then the rate of the reaction is directly proportional to the concentration of the substrate. So first order kinetics, the rate of the reaction is proportional to the concentration of the substrate. Now with the zero order, the reaction depends on an enzyme. This is when the product has formed and the resultant free enzyme immediately combines with excess free substrate. With the zero order reaction, the entire enzyme is bound to a substrate and a much higher reaction is obtained. So the difference between first order and zero order, first order proportional to the concentration of the substrate, and zero order is dependent on the enzyme. A few things that we need to be familiar with the enzymatic reactions are different factors, including the enzyme concentration, the substrate concentration, which you don't see at the top of the slide. pH is very important to maintain in those enzymatic reactions. Are there any inhibitors or activators? Those are all things that are very important with enzymatic reactions. Everything has to be very perfect. Usually when we measure for these enzymes, there's a couple different types of monitoring or measurement that we can do. There can be fixed time, where you wait 2 to 3 minutes and then take your, let's say, absorbance reading on a spectrophotometer if that's what you're using. Or there can be continuous monitoring, where you're taking a reading at 1 minute, 2 minutes, 3 minutes, etc. Moving on to some of the enzymes that we find within the human body. First off, creatine kinase. This is one that we have done in the laboratories that we've done in campus, and I'm sure you've run a great deal of them out at your clinical sites as well. The creatine kinase has 3 different isoenzymes to it: CKBB, CKMB, and CKMM. When we look at each of those isoenzymes, they're going to be found elevated in different types of situations. A BB we find more elevated in things like stroke, and I always think BB, brain. MB is found more in your muscles and your heart skeletal muscles, so if someone were to have had a heart attack, it would be increased. And MM would be more muscle involvement. The next one, LD, or lactate dehydrogenase, sometimes called LDH, is found in things like cancers with high cell turnover, myocardial infarct, and pernicious anemia. There's different isoenzymes for lactate dehydrogenase as well, including LD1 and 2. Those are found in more heart and MI type issues. LD3 found in lung, spleen, pancreas, pulmonary embolism, pancreatitis. And LD4 and 5 is found more in the liver and skeletal muscle. A couple other ones that are very popular are the AST, or aspartate aminotransferase, and the ALT. AST used to be called SGOT as well. That one is found in the liver and skeletal muscle. I always tell students that the S and skeletal kind of go together. That one that you'll find in some heart issues, some muscular issues, as well as the liver. Now, alanine aminotransferase has the L in the middle, ALT. That one is more liver. Now, it is found in other places as well, but it's a lot more specific to liver than AST is. Now, when those two get together, and they're both very, very elevated, that points towards viral hepatitis. So if you have a very elevated AST and ALT, it's very indicative of having a hepatitis. Okay, a few more. We talked about the alanine aminotransferase. Alkaline phosphatase has isoenzymes as well. That one has the liver and the bone portions. Now, there's a way that we can do testing with alkaline phosphatase to see if the total alkaline phosphatase is elevated because of a liver issue or a bone issue. With the alkaline phosphatase, we take the sample, we run a total alkaline phosphatase. From there, we can heat the sample at 56 degrees for a predetermined amount of time, and any of the bone portion will be burned off. So bone burns. What would be left would be the liver portion. So what we would do is take our total alkaline phosphatase, subtract what is left, which would be liver, and that would give us the bone. So we would be able to tell the physician how much of the total alkaline phosphatase was liver and how much was bone. That one we find physiologically elevated in pregnant people and in growing children as well. The next one you see, acid phosphatase, ACP, is found elevated in people with prostate cancer or prostate types of issues. Gamma glutamyl transferase, GGT, that one we find elevated in alcoholics. And my students have always said it looks like go get. Or I had one student kind of crack me up. She thought it sounded like gym tan laundry, if anybody watches Jersey Shore, and they drink a lot. But in any case, GGT we find increased in people that have had alcoholism. Amylase and lipase is found very elevated in pancreatitis. The difference between amylase and lipase some physicians think is a little more sensitive and stays elevated longer than the amylase. Glucose 6-phosphate dehydrogenase has involvement with megaloblastic anemia. And cholinesterase here is one that we haven't talked about a whole lot, but this one breaks down analgesics in surgery. It's found in, involved with the neurotransmission things within the body. All right, we're going to go into a little bit more liver specific here. We just talked about some of the enzymes. We talked about some of the liver enzymes, but we're going to talk more about the role of the liver. The liver plays a critical role in things like metabolism, digestion, detoxification, elimination of substances from the body. So it's like a big cleaner, right? But it also stores amino acids. It conjugates our bilirubin, because if it didn't conjugate our bilirubin, we'd all be walking around all yellow. It regulates our hormones as well. In addition to that, it synthesizes carbohydrates, it makes lipids, it makes proteins. So it has a very powerful job. Without a liver, or a liver that doesn't work very well, you get very sick very quickly because of all these functions it has and all the different things that it synthesizes. It has two lobes and is extremely vascular. If you've ever heard of somebody lacerating a liver, it's always very messy. If you've ever worked in a trauma center where I have, somebody gets stabbed in the liver, which I've seen, it usually ends very poorly. So if someone's going to get stabbed, the liver is not the place to do it. A couple different types of cells. Hepatocytes and Kupffer cells are involved within the liver and working to help that liver out. It is the only organ with the capacity to get rid of heme waste via bile. And just a little interesting tidbit that I threw on this slide is that glutamine is found in the spinal fluid of patients with a hepatic encephalopathy as well. Okay, starting with bilirubin. Bilirubin is the principal pigment and bile derived from the breakdown of RBCs. So first what happens is the RBC takes a little ride through the bloodstream and it makes it to the reticuloendothelial system within the spleen. Once they become broken down, the different parts of the RBC go to different places. There's iron that's broken down and things like that. But what we're looking at with the bilirubin is the bilirubin portion is unconjugated, or also called indirect, travels back to the liver where it becomes conjugated with glucuronic acid. From there, that conjugated bilirubin, which is also called direct bilirubin, is then sent to the intestine via the common bile duct. The intestines turn that conjugated bilirubin into fecal urobilin. Some of the urobilinogen, which is colorless, is absorbed back into the bloodstream and is then excreted by the kidneys. But then some of it is excreted in the feces as urobilin, which makes the feces brown. So when you look at that whole process, a lot of things have to happen. If you have a blockage in any of those areas, that's where you start to have a buildup. So when you look at babies that have that yellow discoloration of the skin called icterus, which can cause brain damage, that jaundice is caused because the baby's liver is immature and isn't able to conjugate that bilirubin as fast as it should. So that's why the little babies turn pretty yellow, because that unconjugated bilirubin or indirect bilirubin is what can cause an icterus and things. Now let's say the bilirubin makes it to the liver. It does become conjugated, but you've got an obstruction. You've got a biliary duct obstruction. That would cause no direct bilirubin to make it to the intestine. When that happens, that's when we find that the stool becomes colorless, because you need all that bilirubin is what makes the poo brown, essentially. So if someone has colorless stool, it could mean that they have biliary obstruction. Okay, going back to the jaundice a little bit here, that yellow discoloration of the skin that happens with that buildup of that indirect bilirubin is usually seen when the levels are above 3 milligrams per deciliter. That icterus can cause brain damage, and the jaundice is the most characteristic clinical manifestation of that liver disease. A couple different types of issues. I just talked about these. Prehepatic, happening before the liver, when you have a buildup of the indirect, can be caused by hemolysis from the red cells, with abundance of hemolysis. A hepatic jaundice can be hepatitis or a blockage. And posthepatic would be something after the liver, such as obstruction in the intestine or kidneys, for example. Okay, bilirubin analysis. We usually use a diazotized sulfonilic acid, and it's called the Gendrasic Groth and Elevin or Malloy-Elevin type reactions that you're going to want to associate with the bilirubin analysis. We do those 3 fractionations. We do a total bilirubin, which includes the direct and the indirect. But sometimes the physician wants to know, okay, the bilirubin's elevated, but why? Is it because of a lot of hemolysis, intravascular hemolysis, or is it because of a biliary obstruction? And we'd be able to tell the physician by breaking that down. In most cases, we test for a total bilirubin and we test for a direct bilirubin. Then all we do is take the total minus the direct to give us the indirect. You need to know that conjugated is the same as direct, and unconjugated is the same as indirect. There's also a protein-bound delta bilirubin that they can test for as well. Definitely not as common as the other ones. We have the jaundice of the newborn, which I talked about briefly earlier, caused by deficiency of the glucuronyltransferase and buildup of that indirect bili. It builds up in the brain and can cause brain damage. Those little babies are treated with bililytes when the bilirubin gets up to 10 or 15 milligrams per deciliter. And when I had kids, they told me to unwrap my child and put him in a window for the light. My girlfriend just had a baby not that long ago, and they sent her home with a blanket that had bililytes inside of it. So it looked like there was a bunch of Christmas lights inside of it. And when they wrapped up her baby, she looked like a little glowworm, which probably was a lot more effective than just a couple hours a day putting your child in the window. Which brings me to my next point. It must be protected from light. You see this little amber-colored tube here? That helps protect the bilirubin from being broken down by light just from within the room that you're in and the light within the hospital or the clinic. We also test for urobilinogen in the urine and feces, which are colorless but oxidized by bacteria and usually produce the brown poo. So those can be of importance as well. Increased levels are found in hemolytic or defective liver function if you've got a lot of urobilinogen. And absence from the urine or stool can mean that biliary obstruction. For the urobilinogen, Ehrlich's reagent is used, and I'm sure you guys talked about this or reviewed it when you did your urinalysis review with Elizabeth last week. All right, a couple alterations that can be found within the liver. Oh, my slide's not cooperating with me here. Here we go. A cirrhosis is when scar tissue prevents normal function. So if someone's been a chronic alcoholic for a long period of time, that liver doesn't recover very well. Another thing is hepatitis C. If you have a lot of things that are damaging the liver over time, you get that cirrhosis, which you can't really recover from. Other things that can happen, you could have tumors that can be benign or malignant, malignant meaning cancerous. You could have, which is caused by liver cell injury, can be with infection of hepatitis C or B. A chronic hepatitis is infection of longer than 6 months. You can have a portal hypertension, which when that occurs, there's obstruction of portal flow, and you can end up with esophageal varices and ascites. Ascites is fluid around the liver. Other situations associated with the liver, RAS syndrome. This is with association of children taking aspirin and having a viral syndrome, usually a high fever. That leads to fatty degeneration of the liver, profuse vomiting, and neurological impairment. Drug disorders, drug and alcohol accounts for over half of all liver failure in the U.S. Remember that GGT I talked about? Go get tequila or gym tan laundry, however you want to associate that with alcohol. There's usually 3 stages of the alcoholics. They start out with a fatty liver. Fatty liver, you can recover from that if you remove the alcohol. Then you can get alcoholic hepatitis, which is an inflammation of the liver. There's some evidence of liver damage. You probably could recover from that. Or you could have severe alcoholic cirrhosis. That's where the liver has turned to scar tissue, and it's very difficult to recover from, if not impossible. Okay, the last thing I'll mention in the liver chapter is hepatitis. Hepatitis A, B, C, D, and E. And you probably talked about this within your immunology class, but it never hurts to hear about it again. Hepatitis A we find in the contaminated food. It's an RNA virus that's transmitted by the fecal-oral route. Hepatitis B is usually sexual transmission or a parenteral or perinatal type of route. And that's the only one that's a DNA virus. Hepatitis C is caused by IV drug use or blood transfusion. That's RNA. Hepatitis D is the one that requires you to be infected with hepatitis B first. That's an RNA virus. And then hepatitis E is very similar to hepatitis A, but it's found more in the developing countries. That one's an RNA virus as well. Okay, that concludes our session of enzymes and liver function.